Hello everybody, welcome to my channel. Case-based questions forever the major theme of a USML test. All questions are case-related in the first step exam. Today I'm gonna start the first episode of a case analysis series. Let's check this out. 77 woman fell and fractured her bone. She has spent most of her time in bed for the past 16 days. She developed sudden chest pain, dyspnea, and diaphoresis. On examination, she has left thigh swelling and tenderness. A chest CT shows areas of decreased attenuation in the right and left pulmonary arteries. A day later, she has difficulty speaking. MRA shows focal occlusion of the left middle cerebral artery branch. Which of the following cardiac abnormalities is she most likely to have? You can pause here if you want to read and think about this case thoroughly. I bet you have found the answer. Yes, you are right. It is D for dog. But why D? Let's start with the first symptom that this patient developed after bone fracture: dyspnea. In clinical practice, dyspnea comes from mainly three reasons: cardiogenic, pulmonary, or other causes. It's a really big story. We can touch on that in late episodes if you are interested. Based on the information we have gotten here, COPD, left heart failure, pulmonary embolism can all contribute to dyspnea. In order to specify, we have to think about associated symptoms, signs, and a history of this patient. In this case, this woman is 77 whose blood flow is slower and blood itself is relatively sticky compared to the young. Especially after staying in bed for 16 days, there's a huge likelihood that pulmonary embolism can be developed in this patient. Thrombus can be formed in the lower extremity vein, then deep vein thrombus travels all the way to the inferior vena cava, later right atrium, right ventricle, finally into capillary vessel of lungs, where embolism appears, leading to poor perfusion of lung tissues, low pulmonary ventilation, then dyspnea can be resulted. This is confirmed by patients' decreased attenuation in the left and right pulmonary arteries on CT pulmonary angiography, CTPA. Why? For the clinical confirmation of pulmonary embolism, CTPA is generally necessary, which refers to that CT scan is performed after injection of contrasted dye into patient's blood circulation. On this image, the areas at the tip of arrowheads are slightly darker than normal, indicating a decreased ability for contrasted dye to enter the pulmonary arteries and branches. This is indicative of a pulmonary embolism. Theoretically, thrombus stops at large arterial branches, so pulmonary embolism only affects pulmonary circulation. However, from this case, we learned that a day later, this patient has difficulty speaking. MRA shows focal occlusion of a left middle cerebral artery branch, which means that this patient is undergoing stroke. So thrombus definitely travels from the right heart to the left, but the only way between left and right chambers is lung circulation, which thrombus cannot pass under normal circumstances. How does thrombus enter into body circulation and block the left middle cerebral artery? This is when patent foramen ovale pitches in. Foramen ovale is very essential for fetal blood circulation, which is closed very soon after birth. Interestingly, foramen ovale of more than 20% population remains unclosed without any clinical presentation. But rising right atrial pressure can lead to the opening of foramen ovale. Then teeny tiny thrombus can travel through septum between right and left chambers, get into body circulation, and obstruct the body arterial branches like cranial artery, renal artery, or splenic artery. This is known as paradoxical embolus, aka crossed embolism. The opening is typically an atrial septal defect, but can also be a ventricular septal defect or patent foramen ovale, normally representing 2% of arterial emboli. Here are some take-home messages you can have. Hopefully all these messages can be helpful for the future studies. Thank you for watching. I'll see you next time.